Hey podcast listeners, Jim Sigler here for Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that comes with it. This week on the program, we're revisiting one of the first topics that we discussed when the show began back in 2016, the physiology of foot drop. The program we put out in 2016 was literally the third episode, and it sounded like I recorded it on a train. So I'm going to replace that with this one. And for any new listeners out there, foot drop is bread and butter neurology, and it's good to know backwards and forwards. So we're going to try to get through it pretty quickly today, cover the high points, and then go over some of the more nuanced details of EMG and nerve conduction studies. Here we go. As I'm sitting here recording the show, I'm a little amused by the fact that I'm still crossing my legs. You all know it's one of the most common causes of foot drop, and we'll get into that. But if it is such a common cause of foot drop, and if it is associated with a slight increase in blood pressure and a slight increased risk of developing DVTs, which apparently it is, and I didn't know that, then why do we continue to cross our legs? If you try to search the internet for this, you might come across some articles claiming that we've crossed our legs more beginning in the 20th century after women's skirts became shorter and they had to sit this way for decency's sake, maybe a few other things. But we've been doing this for as long as we've had chairs to sit in. And kids don't even have to have been taught it, or have to have seen it in their parents to do it themselves. Some will just naturally develop the habit. It's comfortable. But it does cause foot drop. And while that seems silly, foot drop due to peroneal nerve compression is a major cause of falls, traumatic injury, and morbidity. When you're seeing a patient with foot weakness or with difficulty walking, you shouldn't just jump to it being a peripheral nerve injury on your localization. Lower extremity weakness can originate from the paramedian frontal lobe, corona radiata lesions, damage to the posterior limb of the internal capsule. Going down, you can think about lesions to the ventrolateral thalamus, the cerebral peduncles, down into the pontine corticospinal tract fibers, the medullary pyramids, where those fibers have now crossed. You can have damage to the lateral corticospinal tract of the cord, the anterior horn, the conus, and the cauda. And then as the nerve roots exit, finally we get into the peripheral nerve realm. Thinking about it in reverse, lower extremity weakness could also be due to a muscle problem, like a myositis or a myopathy, something wrong with the neuromuscular junction, or more proximally, involving the peripheral nerve axon or myelin sheath. However you think about it, it's always good to rule out these other causes before you jump to some sort of conclusion about the patient's foot drop being related to a peripheral nerve pathology. Next, let's consider the anatomy. One simple approach that I was taught as a resident, and I think it's really helpful to learn, is that when you're evaluating peripheral nerve injury patterns, imagine that the more proximal muscles are innervated by nerve roots that are higher up in the spinal cord. In the arm, think of the deltoid and biceps as being innervated by C5 roots. The extensors of the forearm being further down, they're now innervated by C6 and C7, and thumb opposition and finger extension being more of a C8 function. In the leg, it's the same thing. More proximal muscles are innervated by roots higher up. Hip flexion is mediated by the psoas muscle, L2 and L3 roots, the femoral nerve. Knee extension is L3, L4, also femoral nerve. Tibialis anterior, which is the main foot dorsiflexor and the main muscle responsible for foot drop, this is an L4, L5 root innervated muscle via the deep peroneal nerve. And ankle plantar flexion, which is a medial gastrocnemius and soleus muscle process. This is mostly S1. So, more proximal muscle groups, think of higher root lesions. If that's the only thing that you can take away from today's talk, then you'll get the question right half the time. But this is a neurology podcast, so we're going to get into more detail than just this kind of stuff. At the root level, like I just mentioned, foot dorsiflexion weakness can be mediated by an L4 or L5 lesion. These roots come together to form the lumbosacral plexus and eventually give off the sciatic nerve. Within the sciatic nerve, its two major branches, the common peroneal and the tibial, they're already divided. And this is important because it leaves the pelvis through the sciatic notch, the greater sciatic foramen, underneath the piriformis muscle. And at any one of these sites it can be compressed. The common peroneal nerve supplies almost exclusively the muscles below the knee, with one exception being the short head of the biceps femoris. This is a bit of trivia for the EMG folks out there, because in cases of common peroneal nerve injury, say at the level of the fibular neck, there won't be any EMG abnormalities of the short head of the biceps. but all the remaining lower extremity peroneal innervated muscles will be affected. So the biceps can be a key differentiator here, especially when doing EMG. Unfortunately, clinically it's not all that helpful to test, because the leg muscles are so strong that the long head of the biceps can make knee flexion appear normal. Moving distally, as the sciatic nerve courses within the thigh and through the popliteal fossa, it finally does physically separate into the common peroneal and tibial components. The first branch of the common peroneal is a sensory branch, the lateral cutaneous nerve of the knee. After this branch, the common peroneal nerve wraps around the fibular head laterally, and then it divides again into the deep and superficial peroneal nerves. At the fibular head, this is where you have a high risk of compressive or traumatic injury, from sitting with my legs crossed, for example. The deep peroneal branch is responsible for the strongest dorsiflexor, the tibialis anterior, as well as many of the toe dorsiflexors and the extensor hallucis longus. The superficial peroneal branch, in contrast, assists with foot eversion, which is mediated by the peroneus longus and brevis. And I always remember this because it's the more lateral of the two peroneal nerves, so it drives the foot more laterally. And to test this, you should rest the patient's foot in kind of a flat position and ask the patient to push the foot outward. Being more superficial, as its name suggests, the superficial peroneal nerve also provides a more superficial sensory input from the lateral and the anterior part of the lower limb. This is unlike the deep peroneal nerve, which provides that tiny bit of somatosensory input from the wedge between the big toe and the second toe. So, clinically, how is this helpful? A patient comes in with foot drop, and after thorough consideration of all the proximal causes of limb weakness from the brain to the base of the spinal cord, and after ruling out myopathies and neuromuscular junction disease, how can you clinically distinguish the various causes of root, plexus, and nerve pathology? With a peroneal neuropathy that occurs due to compression of the fibular neck, the patient will characteristically lose the ability to dorsiflex the foot and evert the foot, functions of the deep and the superficial peroneal nerves, respectively. The patient will also lose all sensation along the lateral part of the lower leg and the dorsum of the foot. Importantly, the tibial and sural nerve function will be preserved. So foot plantar flexion, which again is mediated by that S1 root, the tibial nerve, that will be preserved. And ankle inversion, which is a good clinical test, L5, tibial nerve, tibialis posterior muscle, that will also remain intact. In a compressive neuropathy at the fibular neck, this is often precipitated by crossing one's legs, repetitive stretch injury. This has been reported in gardeners from the way that they squat, and in one of the papers that I referenced in the show notes, there's a photo of a woman who's applying makeup by kneeling down into kind of a yoga pose, and she injured her common peroneal nerve that way, by stretching it. Or you can see this kind of injury in patients who rapidly lose weight, and they've quickly lost some of that protective adipose tissue around the fibular neck. Often, injury to the common peroneal nerve at this location can be confused with an L5 radiculopathy, so let's differentiate the two. To do this, you should isolate the muscles that are also innervated by the L5 root, but not the common peroneal nerve. The gluteus medius and the tensor fascia lata, which are both supplied by the superior gluteal nerve off the lumbosacral plexus. These are great muscles to test in this circumstance. With the patient seated, have them abduct their leg against a confrontational pressure. Weakness here, in addition to weakness of foot dorsiflexion and ankle eversion, will indicate an L5 radiculopathy. So instead of getting EMG and nerve conduction studies, you may want to look into lumbar spine imaging and maybe a neurosurgery consultation. More rarely, you may encounter a patient with superficial foot pain, with or without weakness. If it's bilateral, then maybe you'll suspect something like a systemic problem, diabetes, or a nutritional neuropathy. But unilateral limb involvement may suggest a focal process. And two main issues are possible here. First, there can be compression of the deep peroneal nerve at the ankle, the anterior tarsal tunnel syndrome. Or you can have compression of the superior peroneal nerve, resulting in the classic ski boot neuropathy, as some have called it.
And skis, one of the most important things we can do is get you a boot that you feel comfortable in.
In ski boot neuropathy, compression of this sensory branch causes a local anesthesia overlying the dorsum of the foot, without any weakness.
They're going to fit a little bit different, each brand, and so that way we can fit you in a boot that you feel really comfortable with, whether your foot is...
And it can also be caused by tight-fitting shoes, not just ski boots. In anterior tarsal tunnel syndrome, as you would expect, that little patch of sensory input between the first and second toes might be numb, but this is extremely difficult to test. And more importantly, the patient may have weakness of the extensor digitorum brevis, which makes it hard for them to extend digits 1 through 4 of the foot. From an EMG perspective, this is kind of a nightmare. Experts don't recommend the routine testing of the EDB just because focal compression here is so common. And because it's so common, reinnervation frequently confounds the EMG results, and any abnormality will have a questionable clinical relevance. So the EDB is only tested when anterior tarsal tunnel syndrome is suspected, but in no way is the needle EMG a confirmatory test. Alright, let's recap. Much of what we've talked about so far has been recognizing compressive peripheral nerve injury patterns in the lower extremity, but you can get these same patterns with other conditions, like mononeuritis multiplex, severe diabetic polyneuropathy, and I've even had a patient come in with foot drop who was later found to have ALS. So, in many cases, even when you have a slam dunk diagnosis, the EMG and the nerve conduction testing can be useful. Now, we've already briefly reviewed some of the basics of EMG and nerve studies in episode 90, Conduction Block and Why It Confuses Me. And it still does confuse me, but let's talk about it. In compressive injuries at the fibular neck, the nerve study will show a demyelinating pattern early on, because that's what's damaged first. There will be slowing of 10 meters per second or more, and that's what we think of as significant in the leg. And sometimes you can see conduction block, which again is a sign of demyelination and not axon injury. And to remind you, conduction block is when the motor amplitude falls by 20% or more. But if there's a large drop in the CMAP, the motor amplitude, no matter where you're testing, and there is no significant slowing, this would be suggestive of axon loss. Sometimes, if the nerve injury is mild enough or it's too early in the course, it may be tough to distinguish a compressive common peroneal nerve injury to a deep peroneal nerve injury. Because the deep peroneal nerve fibers lie more proximal to the fibular head, they may be more vulnerable to compressive injury than the superficial nerve fibers. So a patient may have foot drop due to a common peroneal neuropathy, but it may be a challenge to clinically detect weakness of foot eversion, and then you get a nerve conduction study that only shows isolated deep peroneal nerve involvement. And this is important because the sensory nerve amplitude, the SNAP, only tests the superficial peroneal nerve, so this too will be normal. What may confuse electromyographers then is that they'll see a pattern of deep peroneal nerve injury. If this pattern shows some axon loss without any focal slowing across the fibular head, then maybe this suggests an L5 radiculopathy, the wrong localization. Which is why you'll probably also test the tensor fascia lata, the tibialis posterior, or some other L5 muscle group to confirm that it is root pathology. Okay, a quick word on prognosis and then we'll wrap up. In most of the early cases of a compressive peroneal neuropathy, there may only be demyelinating changes, and this is good for the patient, as long as the underlying cause can be reversed, like uncrossing one's legs, or not wearing ski boots, or whatever it is. Then the myelin can regenerate, the nerve signal can return, and the muscle activity can normalize. However, if there is axon loss from severe trauma, fibular head fracture, or motor neuron disease, recovery is going to be extremely slow, or even unlikely. So if you've made the diagnosis clinically, you've got a patient with a compressive sciatic neuropathy from sitting in a strange position for too long, the EMG and nerve conduction study can provide a lot of useful information about recovery. Well, I think we've talked enough about the foot for 1 week. Thanks so much for tuning into the Brainwaves podcast. If you like what you heard, be sure to check out some of our other great shows on peripheral nerve disease. We've talked about wrist drop in episode 40 with Laura Minardi, ulnar neuropathies from episode 104 with Noah Levinson, and the strange association between ALS and military service with Colin Quinn, episode 98. If you haven't already, rate the show on iTunes. It really helps us get the word out. Please follow us on Twitter or Facebook at Brainwaves Audio, and let us know if you have any thoughts about today's show or anything that we've put on the podcast so far. The Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. Music courtesy of Lee Rosevere. Sound effects by Mike Koenig and Daniel Simeone. I'm Jim Siegler, Senior Producer for Brainwaves. Thanks for listening.